Hi, I'm Viviane Lanzelotte. I'm a pediatric ophthalmologist from Brazil, Rio de Janeiro. And today I'm sharing with you a very interesting case about a premature baby who developed bilateral cataracts during his screening for retinopathy of prematurity. I'd like to thank LKC for this opportunity. This was a male infant, birth weight of 955 grams and a gestational age of 28 weeks and 3 days. He initiated his IRP screening at the 50th week of life. And at this point, at this first examination, he was stage 0 of IRP. In the second examination, he developed stage 1 IRP in zone 2 in both eyes, and he was stable during his follow-up. But we have a complicating factor during his screening. He developed medial opacity due to bilateral cataracts. As you can see in the first image from his fundus, with a bilateral with cataract with medial opacity, but we can see the line from IRP stage 1. And this gave us a very challenging issue. This progressive medial opacity developed due to the bilateral cataracts, preventing the eyes to continue the retinal evaluation of this baby through binocular indirect ophthalmoscopy. So at this point, we had a challenge. What could you do to continue performing the evaluation of his retina? Indirect ophthalmoscopy was not more possible. PET scan ultrasonography that we have done, as we saw in the previous slide, was a possible tool, but it only could give us the view of some structural advanced complications such as retinal detachment or vitreoretinal traction. It cannot reliable give us the stage of IRP. So we have a clinical dilemma. So we decided at this point to perform the electrophysiological examination of this baby. We performed the ERG with the flicker ERG strategy. We performed in the intensive care unit with the baby without sedation, and we performed mydriasis to help us because of the total. At this point, he had total medial opacity, and it was very fast to do the acquisition of the waveforms, and the baby stayed stable all the time, and we have no issues during this examination with the ERG in this baby. 3 flicker ERG recordings were performed for each eye using the 30 candela and at 28 hertz. And we performed I have said, in the intensive care unit. Although normative data for this specific population are not available, the consistency and the reproducibility of the waveforms within each eye, as well as the symmetry within both eyes, gave us strong confidence about the disease had not progressed to more advanced stage. On the contrary, this find suggested preserved retinal function and a favorable prognosis. Based on this case, electrophysiological assessment seems to be a very useful tool to use in this population of premature babies, especially when fundoscopic evaluation is not feasible anymore, providing us functional insight into retinal status and supporting clinical decision making. Thank you.